I think my presentation is going to be a little different of the other speaker because I am going to give the experience of real life in a private big reference lab. And I agree completely with all what has been said in the morning. I have been involved in most of these recommendations, but the real life and the acceptance of this program is quite different of what has been said. First of all, probably because at the difference of other countries, the cervical screening is performed mostly by the private practice and specifically by gynecologists. So I am going to show you really where are the obstacles and things which are perhaps very simple, but which would have to be imposed, which is quite difficult in France, as you have heard before, because the liberty is very important. Now, every time I do a presentation to the gynecologist or to the pathologist, because I work with them a lot for training, I try to make them accept the new recommendation and the new test. It's a big change for them. And paradoxically, I think the gynecologists would accept it better if their pathologists would have accepted as well, because they are like a couple and sometimes they work together for 20 years. So even if they listen the official recommendation, if their own pathologists do not apply it, they listen or they apply what the pathologist suggests. Now, this is in French, and just show you that in English, it's of course exactly the same, but I suppose you have realized that we are at this step. And even if we all call that now organized system, most of it is still an opportunistic approach. What does that mean? That the patient is used to see her as she called her gynecologist, and she continue to go and do a test, sometime every year, sometime every 2 years, and sometime every 3 years. And we will see in the future if they apply the 5 years interval. But it's really most of the results come from this, in quote unquote, opportunistic approach where we had obtained, before it was organized, 60% of coverage. And what is supposed to be the organized part in the mind of the population is when they receive an invitation. But in the understanding of the state now, and of course of the INCA, they include everything, the opportunistic and the invitation result. So there is a mixed and a poor understanding of the population and of the woman and of the gynecologist as well, that they are to be considered in an organized program. Because it is a private approach, it's their patient, they don't understand why the state asks them anything about that. So that's the first obstacle. Now, the European, of course, and all of you who are very well educated in this field knows that the first recommendation has been proposed by the European guideline has been published in 2015 and promoted, of course, by IARC. And they propose to put the HPV after 30 years as the primary test and the triage by the cytology. And when it was abnormal, direct colposcopy. When it was normal, different possibility, repeat test, cyto or HPV testing. And again, whatever it was chosen, cyto or HPV, 5 years if everything is normal, and if it is abnormal, send it to colposcopy. We have accept, because I have participated with Christine Clavel in this group to the official HRIS recommendation. And we have applied exactly, in fact, the same as the Italian program. Positive cytology, what it is abnormal colpo, what it is normal next year, the year before, after the HPV. We have chosen the HPV, not the cytology, after 1 year, and when it is negative, 5 years interval, when it is positive, colpo. So it's a very quite simple algorithm. So that is the official, now the official French recommendation. What is the application? Now, next one. We here to show you the real life. That is what the clinician has to check. Even if it is in French, and it is, I put it in French to really show you, even if you don't speak French, that it's quite easy. They have just to check before the age of 30 cytology and reflex HPV if needed, after 30 years old, HPV. And if it is the follow-up, there are different proposals where you will need to get an HPV test after 6 months if you have done a conization, because it's now the new recommendation. After conization, to follow the patient 6 months later by an HPV test. After 12 months, if it is an HPV positive at the first step, but cytology negative. After 12 months, if it is colpo normal or low grade. And they can choose in this case as well a follow-up by cytology. So in fact, it should be quite simple for the clinician and specifically for the gynecologist just to check what they are asking. Next step, next slide. The co-testing. Christine, of course, explained, and I completely agree, and all the group agree that co-testing should not be proposed because it has much more disadvantage than the small increase of sensitivity. And the most important disadvantage is to send patients in colposcopy when they are cytology positive and HPV negative, for example, in case of ascus. Next step, next slide. Unfortunately, a lot of pathology, private pathology lab now, even if they know the recommendation, proposed, and I have put in red on purpose the different possibilities they propose, of course, cytology, HPV testing, but as well co-testing. Okay, so when a gynecologist who is not really aware of all these new changes, when you propose to him to exactly when he goes to do buy his food or he go to Amazon, he say, I can get 2 tests for the same price. Okay, I have the 2 tests. Next slide. Again, another example, you know, where they have cytology, they can ask HPV test, or they can ask co-testing. That's the example on another very big lab, private lab again. Next slide. Again, a third example, really to show you that it's an important habit now in private big pathology lab. Again, I put in red, you can ask both tests in the same time, and they don't only say that, they put some references to their practitioner to show that, of course, our official recommendation is to do only one, but that there are other reference publications that show that we can miss some precancerous lesion or invasive cancer. So they really try to influence the gynecology and ask co-testing. Next slide. Now, what was the expected distribution of the test in our program when we have developed this recommendation? That cytology alone should be done only before the age of 30 and represent 20% of all the tests, and that HPV test should represent 80. After an HPV positive, the HPV positive after the age of 30 should be around 10 to 30%. And the colposcopy, I mentioned specifically the colposcopy because I am a president of the French Society, and most of the gynecologists are really concerned about the if the patient will attend the colposcopy. And the colposcopy should be performed if the reflex cytology is abnormal after a positive HPV test. So it should be 30% of this group, which correspond in total of the population to 3 to 5%, which is not higher than what it was before when we got the primary cytology test. The big problem is the second round, because the second round, after 1 year, you will get 50% of the remaining 7 to 10% of this group, which was cytology negative, HPV positive, but cytology negative. They will come back 1 year later, and 50% will remain positive. So it will add the same percentage, and it means it will really double the number of colposcopy to be performed. I show you on purpose the feedback of our laboratory to really explain that if you explain clearly to your gynecologist and just put just one case to check, they apply the recommendation. So in our lab, the gynecologist indeed apply cytology only, and it corresponds to now to 20% of our test. The only change was that the abnormal cytology, it's much higher than before in this group because of low grade. We were not waiting for that to have so many low grade. Indeed, the low grade is a disease of young women. But since cytology is performed now only in the young population, we have the same number of ASCUS, the same number of high grade, but we have more than the double of low grade. It means we will have more patients going to colposcopy before the age of 30. The age after 30, we had 10% of positivity, exactly what was waiting. And I thought it would have been even higher, but no, it's 10%. And the abnormal reflex cytology, it's 27% of this 10%. So it's exactly what we were waiting, 2.7%. This goes to colposcopy. So we have colposcopy for the first round. Now the follow-up. The follow-up at 1 year, we have the remaining which get HPV testing because they were cytology negative. And unfortunately, exactly what I said before, half of them are again positive. So we have colposcopy for this one and colposcopy now for this one, and even more in the second round after 1 year. And we have as well, and that's normal, after conization 3%, and after a normal colposcopy or low grade, 5%. So you see, we had feedback with a number we were waiting and over which are higher than what we thought. Next slide. Now, next slide. The next problem. I show you co-testing. The next problem is, and I put that in purpose in French, I explain you why. Don't read it. It is really much more complicated. They have published this type of test that the gynecologist has to read and check. J'atteste. J'atteste, it means in English, I swear. Never ask a gynecologist in private practice to swear that a paper has been given to the woman and that he has informed his patient that the data will be transmitted, blah, 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 blah. Exactly what Anne said. Never a gynecologist will take half an hour or even 15 minutes to read this text to his patient and after to swear, because it's in front of the law, it's a declaration, you know, and he has to swear that, of course, she's opposed. If she is opposed, that's normal. That the new thing is that he has to swear as well that she's not opposed, and he has never asked that to his patient before. Next slide. So we have tried, and that's our file that we give now to our gynecologist because we have to do it. We have tried to make it much more simple than this text. So we have just put one where she's not opposed and one that she's opposed. During 20 years, we had that she's opposed, but we had never put that she's not opposed. So now the next result is, none of our gynecologists now check anything. They don't take the time, or they don't want to take the time. So we don't have the approbation of any of our gynecologists. So we cannot transmit any more data. And for Île-de-France, we correspond before to 30% of the data. Now they have nothing from our lab. So for me, it's a disaster. Next slide. Now, the suppose organized invitation where the patient receives a letter that she's invited to get a test, blah, blah. It represents 11% of our test, which is exactly the same as before. The fact that it is, in quote unquote, organized, we don't have more invitation where the patient answers to this invitation and send the test. And in this case, again, she has to accept the transmission. I don't understand why we ask the patient to accept when she received an invitation, she accepts to do the test, and now she has as well to declare that she accepts we transmit the data. Next slide, and I think it's my last one. I think the real life is far from what we are expecting from this organized system. First, we have to convince all these private pathologists to apply the recommendation. And I think it's very shocking that they are doing co-testing and that the two tests are reimbursed. And it is a pathologist who said that. I think we shouldn't, that's not my decision and probably none of any of us, but we should not reimburse screening tests in a structure when there are more than 20% after the age of 30 who get two tests, because it means they are doing co-testing. Third, I think we have to convince the clinician to check this famous patient agreement, because if they don't, it's going to destroy completely the program, because we are not going to be able to transmit the data. And all this center and Santé Publique France will not have any data to analyze because we will not transmit anymore anything. And finally, convince the woman to participate. It's exactly what we try to do since 20 years. When we invite an invitation, try to convince them to answer. Thank you very much.